everybody. I'm Mitchell Warren, the director of AVAC, and delighted to welcome you here to what is a remarkably exciting webinar that we have planned. For the next hour, you all are going to get to both hear and then engage and discuss with one of the lead investigators of a critically important study for many years now that is called SEARCH, as you see there. It's been going on for a number of years as the Sustainable East African Research in Community Health Program that has really continued to pioneer some of the most important research in HIV treatment and in prevention. And we're delighted to have Moses Kamya here to present the most recent results coming from the SEARCH study, and this one related to choice. And if you go to the next slide, you'll see very quickly our run of show for the day. I'm going to do just a quick intro and then turn it over to Professor Kamya. And then my colleagues, Catherine Verde Hashim and Wawira Niaga from our product introduction and access team are going to facilitate a discussion with all of you. Please do, as we go, feel free to put comments and questions, any comments in the chat, the Q&A, and then we'll take hands raised. Right now, everyone is in mute, but we certainly want to welcome people off of mute to engage in a conversation on this, and then we'll close it out. This comes at a really incredibly important moment. Here we sit in April 2024, almost 12 years since we first received the first licensure of oral PrEP, oral tenofovir emtricitabine for pre-exposure prophylaxis. And over those 12 years, many of you on the line have been at the forefront of both the advocacy and the programs to make PrEP possible. And yet we all know that in 12 years, we have not seen the progress that we had hoped with oral PrEP and now with a range of additional options. One of the realities in advocacy has always been now for over a decade to talk a lot about choice and how we translate the biomedical options into actual choices that people can use. And I think many of us have reflected on now almost 50 years of contraceptive experience, where every time we saw a new contraceptive method added, contraceptive prevalence went up. And we've always said that as we got more HIV prevention options, we would expect to see the same thing. We certainly did now almost 30 years ago with the introduction of the female condom, which did indeed increase condom use, both male and female. In that time, but it's been a very long wait till we had more products, more options to make available as choices. And if you go to the next slide, you can see a very quick summary. There's a lot of work to try to translate that advocacy for choice into reality. You can see now over 40 projects are either planned and some now finally getting off the ground, looking at options, both the dapivirine vaginal ring and injectable cabotegravir. And you can see on the map a number of countries showing up that are named there that have more than one study or activity, and including Kenya and Uganda, which host SEARCH. We expect over the next many years and hopefully in an accelerated fashion to get more and more data that shows that the advocacy for choice is evidence-based in making calls on donors and ministries of health and implementers and health providers to make these range of choices available to all who might want them and who can benefit from them. But it really was thrilling 2 months ago, or not even, maybe 6 weeks ago, to be in Denver, Colorado, at the Conference on Retroviruses and Opportunistic Infections, or CROI, where a lot of great data were presented, and hopefully my colleagues can put in the chat a number of the roundups related to CROI that happened. And I think many of you know we had the Breakfast Club webinars to highlight some of the key information coming out of CROI. But I think for anyone working in HIV prevention, the session that Moses Kamya participated in an oral abstract presenting the initial data from the SEARCH study was really one of the most exciting parts of the conference. And we immediately wanted to work with the SEARCH team and Professor Kamya to give him an opportunity to present in more detail those data to all of us, and then to have a conversation. So without further ado, and actually I should say on this slide, you'll see that study tracker is a hyperlink when the slides get posted, and I think you'll see that in the chat so you can see in real time what is happening where. But most importantly, want to turn it over to Professor Kamya. The search team is a large team with a remarkable number of investigators in Kenya, Uganda, and globally. Professor Kamya, based at Makerere University, has really been a pioneer in search overall and in the choice study within it. So, Professor Kamya, I'm delighted to turn the screen over to you for your slides and to give you the chance to share with everybody these remarkable findings. And Moses, you're on mute. Oh, we saw the slides for a minute. Ah, fantastic. But you are on mute. So,
Yeah.
oh, there you go. Fantastic.
Yeah.
Over to you.
Yeah, sorry about that. Thank you very much, Mitchell, for the very kind introduction. I'm going to present the early findings of the SARC dynamic choice HIV prevention trials, including injectable cabotegravir. And I'm going to do this on behalf of the large SARC collaboration. So this is the outline. I'll talk briefly about the SARC collaboration and then give a summary of the SARC dynamic choice. When I said SARC dynamic choice HIV prevention, I'll be abbreviating it as DCP. So I'll talk about the pilots that we did, then give a summary of the extension study that included CABEL-A, and then I'll end with summary and conclusions. SARC stands for Sustainable East Africa Research in Community Health. It is a multinational, multidisciplinary research consortium testing bold population-level interventions to end AIDS. It's an ambitious agenda. End AIDS and improve community health and inform policy. The founding directors are written there, Doctors Diane Havria at UCSF, Maya Peterson at UC Berkeley, and myself. We have multiple stakeholders and institutions as listed here, a very high publication record, and an emphasis on supporting young scientists and emerging leaders. So this is a picture showing some of the SARC collaboration members. Not everybody is here, but at least you can perhaps recognize some of the faces. Now, HIV prevention is core to reducing new HIV infections. In providing HIV prevention, there is evidence to show that people want choices. But some questions remain. What do you offer? How do you do it? What do you gain? This slide shows the overall goal and design of the pilot studies that I talked about. We did pilots and then did an extension. So we evaluated the impact of dynamic choice prevention compared to standard of care on prevention coverage. The population we used were adults, more than 15 years of age, HIV negative, at risk of HIV, either by Ministry of Health risk screening tool or self-perceived risk for HIV infection. We carried out these trials in the antenatal outpatients, those who are individually randomized, and also in the community, which were cluster randomized. The primary outcome was percentage follow-up time for which a participant reported use of PrEP or PEP. And then the secondary outcome was percentage of follow-up time at risk of HIV for which a participant reported use PrEP or PEP. The mainstay of DCP, I said DCP is dynamic choice prevention. So the mainstay of the DCP package was choice of biomedical products, but we also included service location, HIV testing, and refill choices. So we offered choices not only in product, but also in service location and testing choice and refill choice. Participants could choose either PrEP or PEP. They could also choose PEP, pill in pocket, with self-test option. Also, participants had the option to switch at any time with changing needs. All clients were offered condoms. And if no product was started at baseline, clients were followed for HIV testing and option to start PrEP and or PEP anytime they wished. The intervention was offered in the context of patient-centered care, and the standard of care was referral to the HIV clinic for standard PrEP or PEP services. So these services are offered by the Ministry of Health. So that was our standard of care. So this graph shows the dynamic choice prevention intervention, and we showed that it increased prevention coverage ranging from 28 to 40% across the trials. I think you can eyeball this and see. Of course, it was much more pronounced in antenatal from 29 to 70, but also in the community. So we showed 28 to 40% increase in biomedical HIV prevention coverage. Now, this figure is you can eyeball it. It is an illustration of the dynamic choice in the community trial. Choice among the intervention participants was dynamic and changed over time. So the top plot shows the trajectory of DCP participants in terms of product choice at baseline and after 24 and 48 weeks of follow-up. Importantly, we see some participants chose and stayed on oral PrEP throughout, while others switched. For example, some switched from PEP to PrEP. And then the bottom plots show choices over time for HIV testing and location of services. Over time, interest in self-testing grew. For example, if you look at self-test, you find that it grew over time. And nearly all participants chose community-based services. If you look at where people chose the location, you can see that that one also, near all participants were out of clinic, and that was their choice. So it is an illustration of giving people choices, not only in product, but also testing and location of where they want to receive services. So in summary, in these pilot studies, these randomized studies with patient-centered model for offering structured choices in HIV prevention, we showed that the dynamic prevention intervention increased biomedical prevention coverage. We also learned that if offered different population with different populations will make different choices. They may want to switch, they will go on and off PrEP or PEP. But we also showed that PEP is currently underutilized and can be a gateway to prevention and participants may transition from PEP to PrEP. CAB-LA was not used in the pilot, but it could increase overall coverage. But there are implementation issues such as how it can safely be delivered in the community, and overall scale-up needs to be addressed. So we were motivated to add CAB-LA and extended the study. So this is what we call the CAB-LA extension study. So because in the pilot studies, the SARC person-centered DCP package increased biomedical prevention coverage compared to standard of care. So it suggested that DCP works, but coverage was still suboptimal. So we also know that in 2023, there were still 1.3 million new HIV infections, despite expanded ART and oral PrEP. So oral PrEP is there, but we still have lots of new infections. And we know about the 2 HPTN trials that showed that injectable CAB-LA was more effective than oral PrEP at reducing new HIV infections. Like I said, oral PrEP programs exist in sub-Saharan Africa, but coverage remains very low. The primary objective of the extension study was to evaluate the effect of DCP with CAB-LA as a prevention option on biomedical coverage as compared to standard of care. And the secondary objective was to optimize implementation of CAB-LA in real-world settings and to conduct rigorous evaluation using the REAIM framework. When we added CAB-LA, we reconsented the study participants and followed them up for an additional 48 weeks. So our study design was an extension of the 3 randomized studies, the ones I've talked about in antenatal and community, as well as OPD, as well as the outpatient department. So it was an extension of those. And then we added CAB-LA in the same settings. So participants were eligible if they were more than 15 years of age with a negative HIV test and reported HIV risk. For patients receiving, sorry, not patients, but participants, for participants receiving CAB-LA, additional eligibility criteria included a negative pregnancy test at first injection, weight greater than 35 kilos, and an undetectable HIV RNA. Our intervention was still the SARC DCP at MOH clinic, Ministry of Health clinics, and community. And it consisted of person-centered care. Now, our person-centered care, in summary, we provided phone access to our participants. So they had phone access 24/7. And we assessed their barriers, to see what barriers they had to participation, to PrEP, and we responded to those barriers. So that was what we called person-centered care. We also provided structured choice. So, between oral PrEP, PEP, CAB-LA, so people had those choices. And ability to switch between or stop products over time, depending on preference and depending on risk. The standard of care was referral for oral PrEP or PEP at local Ministry of Health clinics according to country guidelines. So our primary outcome was biomedical prevention coverage over 48 weeks. We defined biomedical prevention coverage as the proportion of follow-up time covered by PrEP, PEP, or CAB-LA. And the secondary outcome were biomedical prevention coverage during periods of risk and incident HIV infection. This slide shows a study consort. In summary, we enrolled 984 participants in the CAB-RA extension study, and the primary outcome was ascertained in 99% of the participants. This table shows the baseline characteristics. There are about equal numbers of participants by country, as you can see. We enrolled both men and women, but more women because of recruitment from antenatal clinic. This graph shows the primary outcome. The average coverage was 69% in the intervention compared to 13.3% in the control, a difference of 56.4%. In other words, our intervention drastically improved prevention coverage, and there were significant increases across all subgroups. This graph shows that during periods of self-reported HIV risk, coverage in the intervention, which was 76.5%, was also higher than in the standard of care arm, which was 16.2%. This slide shows product use in the intervention arm. Over half used CAB-RA. I mean, they chose CAB-RA during the study, including both men and women. And 42% of those starting CAB-RA were not on any prevention product prior to that, suggesting that when we added CAB-RA, we did not just replace those who were using oral PrEP, but we expanded the pie for those people, for people who were using biomedical prevention. So CAB-RA does not just replace PrEP. It sort of takes care of people that would not have otherwise used a biomedical prevention. So it expands the pie. And as you can see in this slide, some 2% of people used PrEP, 28% used at least 2 different products. Here is a visual summary using heat maps where each row is a participant, each column is a month of follow-up. The purple color represents CAB-RA, and as you can see, lots of purple in the intervention. And in the green color represents oral PrEP, and the blue is PEP. The light yellow represents no biomedical prevention coverage. And as you can see, there's lots of light yellow in the control arm, meaning that in the control, there was, lots of time when people were not on any biomedical prevention coverage. So in summary, CAB-RA was the most selected choice, and use of biomedical prevention varied by arm and by time. This is our secondary outcome, HIV incident infection. 7 adults seroconverted in the standard of care arm compared to 0 in the standard of care arm, giving an incident rate of 0 in the intervention compared to 1.8 in the 0 in the intervention versus 1.8 in the standard of care arm. In addition, 1 infant born to a participant in the standard of care arm was infected, but we did not include them in the incidence calculation. So our study was implemented in a real-world setting without CAB-RA oral leading. So it was direct to inject. We didn't do oral leading. We also accommodated for travel by giving oral prep during those periods when people traveled. We also gave an option to continue CAB-RA for women who became pregnant. As I said before, people who became pregnant during follow-up were given the option to continue after signing informed consent. So study participants who received at least one injection of CAB-RA were followed for adverse events. We observed no SAEs related to CAB-RA. We observed grade 2 rashes in 7 participants, 3% within 15 weeks, with unknown relationship to CAB-RA. We did not see any hypersensitivity reactions. So in these 7 participants who had rashes, we stopped CAB-RA because we work in rural areas and we did not want to take any risks lest those rashes progress. So in those participants, we stopped CAB-RA. There were 13 pregnancies among women who had received at least one injection of CAB-RA, and about half of those chose to continue. So in conclusion, our SARC DCP model was highly effective and increased biomedical coverage by more than 5-fold and reduced HIV incidence to 0. We observed that people want product options, they chose different options and changed over time. Person-centered choice models and wider access to CAB-RA are needed to increase biomedical coverage. I would like to acknowledge the study participants and communities, governments of Uganda and Kenya, the principal investigators, co-authors, the NIH, VIV Healthcare, and the entire SARC team. Some are not included on this slide, but lots of people contribute to these studies, and I would like to acknowledge them. So I'll stop there. Thanks very much again for the opportunity to present. So I would welcome questions. Over to you, Chair.
Thank you so much, Moses. That was my video on. So we had one question already in the chat. Were any new participants enrolled in the extension arm, or had all been in the pilot phase for some time?
So all the participants who were enrolled in the extension arm had participated in the pilot. So we did not enroll any new participants.
Thank you. And we have one other question here in the chat from Jim Piggott. How can we demand more research into HIV prevention modalities that are not long-acting and systemic? We need options that are on-demand, user-controlled, short-acting, and non-systemic, yet the pipeline has very little of that. I don't know if you have any thoughts on that, Moses?
I guess that's a comment, and
Yes.
I think that is well received and sounds correct.
Thanks very much. And then we also there's one question so far in the Q&A where there's someone in the DRC who would like to get involved. So maybe I can pass their information along to you afterwards.
All right. Sounds good.
Great. Okay, and yes, also just want to remind everyone, you can also put your hand up if you'd like to speak in addition to adding questions to the chat. So we have another question that's just come through. What were some of the critical structural barriers you identified and measures you took to address them?
So what were the critical challenges and what measures did we take to address them? certainly when we started, we had to do a lot of preparations, do the training, make sure everybody understands, do the SOPs, and do all the preparatory work. While we conducted the study went very well. The providers did not find difficulties in explaining the study. Certainly, some people felt pain when they got the injection, and yeah, I don't know whether that's a challenge that was expected, meaning that one needs to counsel patients about pain. Some people become mobile, they move, and you need to anticipate that and make sure. That's why I said that we bridged that gap. If people could not come back for injections, we made sure they were on oral prep. So I don't know. I think there's lots of preparation when you are going to give CAB, but we did not face too many challenges. By the way, there are people in the room that are part of such, and I would welcome their, additions to whatever response I give. I can't see all of them here. I think they are hidden. But I think Dr. Kakande, you are there. Laura, you are there. I know you are in the room and you can add.
Thank you so much. And yes, if the other search investigators want to put your hand up, then we can also unmute you. So if you'd like to add anything. We have quite a few more questions, so thank you so much for keeping these coming. We'll go through the questions in the chat and the Q&A, and I'll see, Bridget, you have your hand up, so we'll get to you as well. We have another question here. Is there any information on the health workers' experience with CAB-LA preparation in the rural setting?
Yeah, we are currently analyzing our qualitative data and implementation data, and we are hoping to present a lot of that during the Munich meeting, if people will be there. But what I can tell is that our preparations through training and SOPs and support, and of course we also got this what do you call it, a communication tool from Mosaic, so that providers can explain. So in short, we did not have significant challenges. I mean, from the providers, perspective, yes.
That's great, thanks. And now we have a few questions here about dynamic choice counseling. So we have here one about how did you ensure that individuals are empowered to make informed decisions while considering their evolving vulnerability factors and personal preferences? And we also had a similar question regarding dynamic choice counseling. We know it includes key components of patient-centered care, like structured assessment of barriers, STI services, and psychological support, but the standard of care does not. Are you able to tease out how these patient-centered components are contributing to the outcomes of your study? So if you want to speak a bit about that dynamic choice piece.
Yeah. So I think the first question was about counseling and how. What was it about counseling that?
So ensuring that individuals are empowered to make informed decisions.
That individuals are empowered to make. We tried our best to explain like I said, it takes some preparations, making sure that providers are trained, and then they explain, and then we've got this. The Mosaic tool is a very good one, explaining like the pill can do this, it can't do the other, and it takes some time to explain, but also we've got the we provide phone access. So if somebody finds difficulties, we can have like continued counseling to make sure that if people face any challenges, they are able to ask. So it takes time to explain, but eventually, people understand. Certainly at the beginning is slower. As you get used to explaining, as people get used to what oral and injectable can do. But it is doable, and yeah. So continued counseling, I think it's not a one-time, and using some visuals, some communication tools. And then somebody was asking about how could we tease out what we offered person-centered care, we offered product choice. So I really don't know. I think in implementation science studies, sometimes you're not able to tease out exactly. But definitely, we saw that people changed over time. They switched products, meaning that, they understood, what can work for them. Somebody could come and say, look here, I think that I get coerced into sex, and therefore I need PEP, or asks what would work for me. So I think that we are not able to tease out what I mean. We provide all of this in a person-centered care context, and providing choices. And so I don't think we can tease out really what. Let me ask Laura, my colleague Laura. Laura, do you want to comment on that? Is she? I'm sure she's there somewhere.
Yes, let's see. I can just unmute her. Here you go, Laura, please.
Wonderful. Thank you so much for your interesting questions. Thank you, Prof. Kamya, for your beautiful presentation. So this is a fantastic question about how do we tease out the effect of individual components in these multi-level, multi-component intervention packages. And as a biostatistician, I will just say that the statistics around that are quite hard to do formal mediation analyses. In the meantime, we are conducting robust qualitative analyses and qualitative studies and interviews and focused group discussions to really explore what Dr. Kamya said about who works, what works for whom, when, and why, and how do we package it all up together. Thank you.
Thank you very much, Laura.
Thank you so much. And now, continuing on the theme of the discrete choice intervention, we have a question here. I'm curious about the comparison of the discrete choice intervention to the standard of care at Ministry of Health clinics as the control, as the two are extremely different. In addition to the package of intervention and choices offered in the discrete choice arm, one would assume the discrete choice arm is much higher quality experience for an individual. So can we say the discrete choice outcomes are because of the choice and package of interventions offered, or was it more about overall higher quality experience than going to a standard clinic? Do you have any thoughts on that one?
Yeah, very, very difficult questions.
Yes. Yes.
I think that we aim to see how we can offer choice and all the things that we did. We definitely recognize that the standard of care did not have access to the same clinical, to everything that we did for the intervention. But I think we have evidence now about certain things that can help us increase HIV prevention coverage. I mean, we look forward to applying these to the standard of care. It may not be exactly in the same way, but in some kind of modified way. Elijah, do you, again, my colleague, Elijah Kakande, would you like to add something to that question?
Thanks, Elijah. If you raise your hand, then I can just unmute you. Great. Great, Elijah.
Yeah, thank you. Thank you for those questions. I think the question was about, was it about discrete choice experiments or, sorry, Catherine, if you could just.
Yeah, sure. So this is about, because the discrete choice arm, we're having a higher quality of experience for the individual. So can we say that the outcomes in that arm were because of the choice and package of interventions offered, or was it just about the overall higher quality experience compared to going to a standard public health facility?
Yeah. Agreed. That's a good, I think it's a very good question. And I think Prof has alluded to a lot of the components. So as much as possible, we try to integrate what we do within the Ministry of Health system, really, so that whatever we're offering, we know that it can be sustainable over time. It's difficult to tell that, to say whether or not the quality of care that we offered did not have something to do with the difference, but certainly we think that what made more of a difference are the components of the intervention. And certainly we are working on some of the qualitative work. I think there are some papers in process that show that indeed participants appreciated a lot the components of the intervention. So certainly we know that from the participants and from their experiences, what they appreciated more was the intervention itself. But certainly it's a fair point to think that quality of care has something to do with it.
That's great. Thank you so much. Now we have quite a few questions I still want to be able to get through, so maybe we can answer some of these a bit quickly. So now looking at the different choices people made, do you have any thoughts about why CAB was the most popular option? And are you doing any qualitative research to follow up on why people chose CAB?
Yeah, do we have any insight why CAB was? Yeah, CAB, you see, you get the injection, and then for the next 2 months you are okay. I think that there is less stigma. Yeah, of course, the problems, the issues around oral PrEP, the pill burden, the stigma of taking tablets and taking them home, and people asking what are you taking. I think the injection, first of all, takes away the pill burden, takes away the stigma, takes away the responsibility to take. So people found it convenient, but also you could see that many people stayed on PrEP. On oral PrEP. So it's not like oral PrEP has no role. Some people chose it and stayed on it. So I think that's why we think that the success is going to be in having choice, and the more choices, perhaps the better. And we are going. The more choices we'll have, the better the coverage. For HIV.
Yeah, no.
Yeah.
Absolutely. And related to that, we have another question in the Q&A. Noticing, like you said, that even oral prep use went up in the intervention arm. And just if you have any thoughts on that, and could this be explained by people who had initiated CAB but needed to switch for some reason? They needed to travel or stop CAB.
No, I think the people who chose oral prep, they had a reason. Some people did not want injections. No, not everybody wants injections, and some people fear pain, and they would rather take their tablets, and so yeah, it's kind of, and of course, you know, oral prep people can, yeah. So it's you know, people's preferences. I think respecting preference is a very important part of HIV prevention. I think we need to respect people's preferences. So, so they might, like I said, if people fear injections, they could take oral prep, and yeah.
Yeah, no, exactly. Thank you so much. Now we have some questions in the chat about scalability and sustainability. So could you speak to the scalability of the model that Search is evaluating? And we also have a question about, could it be extended to other countries in East Africa?
So what is the scalability? What is the sustainability? We believe that our intervention is sustainable, but we know and understand that it will not be implemented exactly the way we did it. For example, you can think of, we provided phone access to our participants. And you could argue that, for example, in a normal clinic, the healthcare provider who is on call, who is on duty, maybe could be the one receiving the calls. So in our case, it was like, you know, it was kind of a study setting, and we had the calls 24/7. But you could argue that maybe somebody on call may be okay to receive, who is on duty, like who is taking care of patients during that during that period. Maybe, you know, that person may be able to receive calls from participants. So it may be done in a different way from what we did. But also we also, as you may have noticed, we had the community side, and they had community health workers. We call them village health teams in Uganda. So those who work in the community, and it is possible that those people could answer some of the challenges of which the participants might have. So I think that what we did is sustainable, but not in the current form. It will need to be adapted. But we have some systems that you could look at and say, oh, look here, you know, somebody on call could take a phone, some VHT or community healthcare worker could answer questions, could, you know, could address client challenges, things like that.
Thank you so much. It's a lot to think about when thinking about scaling up. Now we have a few like very practical questions here that I'll just hand over to you. There's a question about incidence of rashes, and if CAB was only given in the buttocks or if patients requested other administration areas. And we also want to know if the study looked at STI incidence. So 3 kind of very practical implementation questions about the rashes, injection site, and if you look at STI incidence.
So what was the question about rashes? What What about
But did you see more in one country or the other, or was it the same in both?
Yes, yes, we actually saw rushes in one country compared to the other one.
Which one was more?
In
Oh, you don't
Uganda, it
remember
was more. Elijah, wasn't Uganda more than Kenya?
Oh yes, Elijah, please go ahead. I think you can unmute yourself now.
That's correct. We had more in Uganda than in Kenya. I think 5 out of the 7.
Yeah. So
Interesting.
yeah, it's quite interesting. So yeah, it was more in Uganda than in Kenya. So the next one was, so Elijah, could you, I don't want to talk alone. The injection, was it given in other sites as well? Could you?
No, so it was only in the buttock. And this is also partly what Dave recommends currently. So there's, I think, partly because we don't have so much data to support other injection sites. So we stuck to that within the study.
Thanks,
And
Elijah.
then, would you like to comment on STIs as well?
Yes, with STIs, we conducted STI screening at every visit and managed participants who had STIs according to Ministry of Health guidelines, but we didn't add them to our measurements. So we don't have, I think the question was about incidence of STIs. So we don't have those data currently.
Thanks, Elijah. Now we have a few questions about tools that you're using. So there was a Mosaic tool you mentioned that if you could just share in the chat, someone from the team, which Mosaic tool that was. We can also put a link to that for PrepWatch if you can share the name. And then we also have a question about the choice-based counseling, if you had a standard tool used for that other programs could also use.
Yeah, thank you. I think we'll be able, we'll follow up with you, Kat, on that.
Great.
About the sharing, yes.
Perfect. And Mawira, please go ahead.
Now, thank you. I have one question in regards to access for people that were put on CAB. And I wanted to know whether the participants still have access to CAB. And also the other question I have is, given your experience, Prof, what are some of the practical considerations and advice would you give around offering CAB to implementers? In this case, we're talking about testing, about delivery site preparation, and how to train providers.
Yeah, thank you very much. Access to CAB. Right now, the people who initiated CAB in our study are still on CAB. They are still accessing it. We are hoping that, Global Fund is likely to buy some doses, and we hope that, the people in the standard of care will also receive. But of course, sustainable supply is still something that we are not completely certain about. But for now, those who are on CAB are taking it, and we hope that we will be able to take care of the standard of care when we get some doses from the Global Fund. Now, the other question was about what practical advice. I think practical advice one would give to people who want to implement CAB wasn't that the question?
Yes, because we have a couple of countries that have started, and we have others that are also studying. What are some of the practical considerations and advice would you give to them?
Yeah, I think that first of all, one needs to prepare for CAB. You don't just begin like tomorrow if you are thinking about it. So there's need to sensitize the community. There's need to train providers, including Ministry of Health staff. So need for training, need for community sensitization. There's also need for storage facilities, for the drugs. I think people need to think well ahead about storage. Another advice would be that the people preparing to give CAB need to be ready to proactively follow up with participants once they initiate injections. Remember, if you take an injection and people don't come back, and then there is the tail and whatever, and then resistance development. So one needs to proactively think about follow-up. How they will be follow-up. And of course, the counseling bit, people need to, have a counseling protocol about, telling people about the possibility of injection site reactions, because those can happen, especially pain. Counseling people about pain, that this will pain a bit, so that people don't get unexpected pain. But we also think that I think that in resource-limited settings, we are not going to do, at least this is a personal opinion, we are not likely to have enough resources to do HIV RNA testing, each time somebody is going to receive a CAB injection. So I think the way we did it, doing HIV RNA testing every 6 months, may be a compromise between, doing it before each injection and not doing it at all. So doing it every 6 months may be a compromise. That is just a personal opinion. But all the other things above need to be in place before you begin CAB.
Thank you
Did
so
I
much.
answer?
That was
I
a
hope I
great
answered.
answer. And I'm so glad you raised the testing issue, because that's something that we're going to be exploring more very shortly. But I know we only have just a minute left. Very quickly, Heather asked in the chat, why wasn't the ring offered? Now, I think you might be offering the ring soon. If you want to just very briefly speak about that.
Yes, I think you are right. We got the ring and we've added it to to the options. And I think maybe in the next 1 year, we will be able to say what it adds to the options. So it is too early. We just started it recently, and we don't have enough data to share. Yeah. But
That's
that
great.
is another option. Yeah.
Thank you. That's great to hear it's going to be an option. Now, I'm sorry, Bridget, I don't know if I have time for your question, but if you want to send me your question after, then I can follow up with Professor Kamya. I think I need to hand over to Mitchell now to wrap us up, because we're in the last minute of our webinar. And thank you so much, everyone, for the amazing questions.
Fantastic. No, Kat, thank you. That was beautifully done. Prof. Kamya, maybe just quickly, I know we're just at time, but any last thoughts from you before we close out?
Well, I think the last thought from me is really we hope that we can have access to these prevention modalities. We can have access to CABEL-A and perhaps others in the pipeline. As you saw, we literally shut down new infections by offering CAB. So I think that access to these products is very important if we are to make progress in our HIV prevention and in attaining epidemic control by 2030. I think we need all these prevention options to be given to our clients with a choice to choose between them. And so access is going to be an issue. And I think that we hope that we shall have more access for our participants.
Great. Prof. Kamya, I want to thank you and the search team. You all pioneered some of the work related to testing and treating at scale, the integration of testing and treatment into community health, and now showing us that indeed you can get incidence to zero, at least in the study as you all designed it. And it is thrilling to watch. And so much more to do, both in keeping you all able to scale, to add additional methods, as Kat and Heather described, the dapivirine vaginal ring, as well as thinking about the next generation of products to come. So I want to thank you and the team for doing this. Clearly, there were questions in the chat we didn't get to related to PEP. Related to a range of other issues, which we will come back to. I do want to just flag that next month we are doing a webinar about HIV self-testing and PrEP coming up on May 23rd. And then there'll be larger conversations about HIV testing generally, as you just described, Moses, and how important that is. So I want to have people mark your calendars for this. Because this is such a dynamic place. And so you described it and started us talking about dynamic choice. It is a dynamism in the field. And want to just highlight one other thing that you said, I think perhaps the great slide showing zero incidence in the arm of choice is critical. But early in your presentation, you showed that there were actually 3 choices. There were choices about products, choices about service delivery, and choices about HIV testing. And it really does underscore that no matter how good any of these products are, condoms, oral PrEP, circumcision, vaginal rings, injectable PrEP now, and injectable PrEP of the future, if we don't also provide options with respect to programs, then we won't actually translate any of those biomedical options into impact. And so I really want to thank you, Moses, because I think you started by that clear message that it's choices on multiple levels, not just about the products. And I think the conversation relating to the question about the control arm, and it's different than being in a public clinic, really underscores that. It's the program, not just the product. And fundamentally, and I think I'll take this quote from you and keep using it, respecting people's preference is key to HIV prevention. Respect and centering everything we do on the people that we seek to serve. You said it so well. So thank you, Moses. Thank you, Search, for what you've delivered. And I know advocates around the world who've been voices for choice are thrilled to now have evidence to help amplify those voices for choice even more. Thank you all. Definitely May 23rd on HIV self-testing in PrEP, and many more conversations. And we'll look forward to more data from Search in Munich and more data from all of the other projects, many of which represented here on the call, in webinars and conferences and activities to come. So thank you all, and have great evenings, afternoons, and mornings. And again, Moses, thank you so very much. And please pass it on to your whole team. Cheers all.
Thank you, everyone.
Thank you. Bye.